So, good wishes, everybody. I am Dr. Aravinda Jagadeesha from Bangalore, India. So, first of all, I extend my good wishes and uh, for the success of the seventh International Annual Conference of Egyptian Cardio Diabetic Association. I would like to congratulate and send my good wishes from India to Professor Nasser Yusuf, Professor Manal, Professor Sohar Kasem, Professor Tarek, Professor Momin was, all the presidents, secretary, and board members, a good wishes from India. And first of all, I would like to thank Professor Nasser Yusuf personally for making me a part of this conference and giving me a wonderful topic to present. Today, I'll be presenting choosing the right antihypertensive in a diabetes patient. So, this is my CV. So I am Professor Arvind Jagdish from Bangalore. I've done my MD, MRCP, triple FRCP from UK, and I have my own diabetes center in Bangalore, which is in the south part of India. So first of all, greetings to all of you from Bengaluru, from India. So, coming to the topic per se, the world is facing double trouble condition. That is a tremendous increase in the coexistence of diabetes and hypertension has been observed recently in the world. So, the deadly duo in the world, that is a high prevalence of hypertension in diabetes population, is 58%. So it is a vicious twins. So the two giant disorders often comes hand in hand with each other. So the new onset diabetes is 2.5 times in hypertension. On the right hand side, you can see hypertension is about twice as frequent in individual with diabetes as in those without. So the deadly duo, that is diabetes and hypertension, share the same pathophysiology. You can see here on the right side of this slide, at the top you can see the diabetes mellitus, at the bottom you can see the hypertension. So at the top you can see diabetes mellitus, there is insulin resistance and hyperinsulinemia and hyperglycemia. You add anti-diabetic agents. At the bottom you can see the hypertension. In the middle you can see the common pathophysiology, that is inflammation and oxidative stress. The inflammation leads to neurohumoral activation. There is RAS, renin, angiotensin, aldosterone system increased, sodium and volume retention, and sympathetic activity is increased. The oxidative stress leads to vascular remodeling, endothelial dysfunction, arterial stiffness, peripheral arterial vascular resistance is increased. So on the right, is both the side, you can see the common pathology. You have the genetic factors and you have the environmental factors. This slide is an important slide which share the same pathophysiology for the deadly duo of diabetes and hypertension. So it worsens the premature complications with the deadly duo. The common risk factors promote diabetes and hypertension, which are associated with atherosclerosis, vascular inflammation, endothelial dysfunction, and structural remodeling, which lead to macro and microvascular disease. The common risk factors, that is insulin resistance, dyslipidemia, genes, and obesity, leads to diabetes and hypertension. Both of these are interlinked, causes the atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling, leading on to macrovascular disease and microvascular disease, ultimately the major cardiovascular disease. The putative mechanisms whereby diabetes and hypertension cause vascular complications. You can see in this, the diabetes and hypertension together, they cause, like, the diabetes causes hyperglycemia, the RAS system involvement, immune activation, oxidative stress, inflammation, and miRNA. All this leads to macrovascular and microvascular disease. So, the need of BP control in diabetes, the most patients with both disorders have a markedly worsened risk for premature microvascular and macrovascular complications. The presence of hypertension causes a 7.2-fold increase morbidity and 37-fold increase in mortality in diabetic patients. So the increment of risk associated to hypertension based upon age and sex group. You can see in this slide the presence of hypertension in patients of diabetes largely increases the risk of MI, stroke, heart failure, and all-cause mortality. The impact, even it is higher in more younger patients, it's still until the last decade of life. This is the slide which shows the increment risk of hypertension by age and sex group. Certain special characteristic of hypertension in diabetes mellitus, you can see in this slide, the nocturnal hypertension in diabetes mellitus, the lack of nocturnal dipping in arterial blood pressure has been demonstrated both in type 1 and type 2 diabetes. The lack of natural dipping is associated with increased risk of stroke and myocardial infarction. The nighttime blood pressure control becomes especially important in diabetics. The excessive salt sensitivity and increased extracellular volume. The blood pressure of a diabetic patient is more sensitive to salt intake, and this sodium sensitivity is found even in absence of nephropathy. A decreased salt intake is important for diabetic patients with hypertension. So, diabetes, hypertension, and nephropathy, increased systolic blood pressure is a significant risk factor for microalbuminuria and rapid progression to nephropathy. Isolated systolic hypertension is strongly related to the development of micro and macrovascular disease in patients with diabetes mellitus. So, the goals of therapy, the American Diabetic Association recommends target blood pressures of less than 130 by 80 millimeter of mercury. In pregnant patients with diabetes and chronic hypertension, the blood pressure target is between systolic of 110 to 129 and diastolic of 65 to 79 millimeter of mercury are suggested in the interest of long-term maternal health and minimizing impaired fetal growth. So the advantage of BP control in diabetes. In the UK prospective diabetes study, that is UK PDS epidemiological study, each 10 millimeter mercury decrease in the mean systolic blood pressure was associated with the reduction in risk of 12% for any complications related to diabetes, 15% of the death related to diabetes, 11% for myocardial infarction, 13% for microvascular complications. So, the coming to the management, which is an important part, a comprehensive algorithm encompassing all the armamentarium you can see on the left hand side. It's a simple slide, simple chart which helps you in deciding when to start the treatment and what to start the treatment. Like diabetes with the blood pressure, the target, if it is less than 130 by 80, no need to put anything, just follow up 3 months. If it is not, if the BP is blood pressure is systolic blood pressure is 130 to 139, diastolic blood pressure is 80 to 89 in 2 visits. So you ask the patient to do the lifestyle modification, that is diet and exercise, and follow it up. If the blood pressure is more than 140 to 140 by 90, or if the urine albuminuria is positive, then you can start the first line therapy, that is the AAC inhibitors or ARBs or thiazides if no albuminuria. So after 1 month, you reassess the blood pressure status after putting this first line therapy. If there is persistent of blood pressure more than 130, you can add calcium channel blocker or beta blockers or combine AC inhibitors or ARB with the thiazide. If still it is more than 130 by 80 after 3 or 4 drugs, so you label it as resistant hypertension. You can add spironolactone as well, take an opinion from the hypertensive specialist. So, this is the recommendation from the European Heart Journal for the treatment of hypertension in patients with diabetes. You can see here once again in adults with diabetes and hypertension, antihypertensive drug treatment should be initiated if the BP of 130 by 80 millimeter of mercury or higher with the treatment goal of less than 130 by 80. In adults with diabetes and hypertension, all first line classes of antihypertensive agents, that is, diuretics, AC inhibitors, or ARBs, or CCBs, are useful and effective. In adults with diabetes and hypertension, AC inhibitors or ARBs may be considered in the presence of albuminuria. So the ESC guideline recommendation for uncomplicated hypertension. This is the European Society of Cardiology. Once again, you can see the initial therapy depending upon the blood pressure. If the blood pressure is one less than 150 by 80 or 150 systolic or more than 80, you can see the first line therapy can be dual therapy as well, either the AC inhibitors or ARB plus CCB or diuretics. In the step 2, it can be triple therapy, triple combination, that is AC inhibitors or ARB plus CCB plus diuretics. In the step 3, if the patient is have to a resistant hypertension, you can add on spironolactone. And beta blockers can be considered at any treatment step when there is a specific indications for their use, example heart failure, angina, post MI, atrial fibrillation, or younger women with planning for pregnancy. So the ADA hypertension treatment algorithm, you can see on the right hand side, very beautifully shown about the how to go on with the patient to start antihypertensive in a diabetic patient. You can see in the right hand side, if the initial BP is between 140, 90 and 160, 100, you start one agent. If it is more than 160 by 100, you can start two agents. Then, depending upon the albuminuria, whether it is present or absent, you can use AC inhibitor or ARB plus CCB or diuretics. Assess the blood pressure and look for any adverse effect. If the target is maintained, continue the therapy. If the target is not met, you can add on therapy depending upon what the patient is on, like CCBs or diuretics. Assess BP again. Once again, if there is not control, you can add mineralocorticoid receptor antagonistic as well as take the reference to hypertensive specialist. So, key recommendations for practice by American family physician. If we take the target blood pressure in patients should be less than 130/80. AC inhibitors and ARBs are the preferred agents. If target blood pressure is not achieved, you can add on thiazide diuretics. Beta blockers should be used as a part of the initial antihypertensive regimes in patients with diabetes and a history of myocardial infarction, heart failure, coronary heart disease, or stable angina. Dihydropyridine calcium channel blockers should be reserved for patients with diabetes who cannot tolerate preferred antihypertensive agents or those who need additional agents to achieve target blood pressure. Most patients with diabetes require therapy with a combination of antihypertensive agents to achieve target blood pressure. So, from various studies and guidelines, the following are observed. In diabetic hypertensive, the goal should be less than 130 by 80. Behavior therapy alone, maximum 3 months, then add pharmacological treatment if 130 by 90 or 80 by 9 more than 130 90. On the right hand side, you can see behavioral therapy plus pharmacological treatment if it is more than 140 by 90. So choosing right antihypertensive as per our Indian RSSDI guidelines, once again, the first thing they always we say the ARB is either alone or combinations with CCB can be used for blood pressure control. The combination therapy or ARB and CCB is recommended to be initiated in hypertensive patients for better blood pressure control. In this slide, There is an important statement you can see on the right hand side. ARB must be preferred over AC inhibitors in diabetic patients with hypertension, like telmisartan or azilsartan, being selected as the first line agent. Calcium channel blocker must be preferred over beta blockers and thiazide in combinations with ARBs. Cilnidipine is a comparatively more effective and safer novel molecule as compared to the conventional CCBs for the Indian diabetic hypertensive patients. On the left hand side, you can see among the ARBs, telmisartan, and among CCBs, cilnidipine are the preferred agents in the management of blood pressures in diabetic patients. Even combination therapy with CCB and ARB is preferred over the other combination therapy. So the major drug combinations with efficacious results, you can see here, it can be RAS blockers, that is ASC inhibitors, or ARB with calcium channel blocker, or with diuretics, or with beta blockers. These combinations can be definitely used. So if you say the summary of various guidelines, or this is the summary of Indian RSSDI guidelines, you can see management of hypertension in patients with diabetes. You can select from among these ARBs, AC inhibitors, CCBs, and diuretics. Among the ARBs, telmisartan is preferred. Among the CCBs, cilnidipine is preferred. Diuretics in cases of resistant hypertension and elderly patients. So this is the major statement for the use of antihypertensive in diabetes. So the guidelines for managing diabetic hypertensive, the main thing is, ladies and gentlemen, uh, the first thing is the target blood pressure should be below 130/80. All routinely used antihypertensive drugs have been shown to beneficial compared with the placebo. More than one drug will be usually be required to achieve the target BP. Patients with pre-hypertension should be given lifestyle behavioral therapy alone for a maximum of 3 months, and then, if targets are not achieved, should also be treated pharmacologically. The choice of drug should always include an AC inhibitors or ARBs depending upon the situation. Then add on calcium channel blockers or diuretics. If additional therapy is needed, you can add stews between the calcium channel blocker. If there is a cardiac event, beta blocker should be the preferred agent at any point of the management of hypertensive armamentarium. So, thank you for your patience hearing. I once again wholeheartedly thank Professor Nose Yusuf for making me a part of this conference, and I wish you all a uh, pleasant and happy conference. Good wishes for the conference once again, and greetings from India and love from India. Thank you so much for your patience. Thank you.